Okay, we're going to start very soon. Welcome to Congenital Heart Hour. My name is Salim Jivanji. As you know, this meeting is about congenital heart disease and its impact and treatment. The topics this year will be broader and also cover some EP topics which have been requested on our feedback forms. The topics we will discuss will be around congenital heart disease, clinical management, service delivery, and challenges. It'll also include new and existing treatments, which will include both surgical and cardiac catheter. We'll also have other specialties which are going to come and speak to us about the impact of their special interest in the delivery of congenital heart disease like today. I'm also excited to say that the number of speakers from international centers will increase over the year. I'm happy to report that our community is growing with an audience of about 24 countries now and a weekly audience of about more than 120 attendees. Before I introduce today's talk, next week we're going to have Mr. Ram Danapaneni, who's one of our lead surgeons here at Alder Hey. He's got a couple of topics that he wants to talk about, and he hasn't confirmed as yet what he's going to talk about. So we will send out a notice by next week in terms of what it's going to be. But be sure to attend as he does most of our complex congenital heart work here. Please try and join in either physically or virtually. I would like to also thank our sponsors who make these talks a success. Today, our talk has been sponsored by iCardiology, and we are very grateful for their support. During the talk, if you have any questions, please place it on the Q&A, and we will address it at the end. So today is my real pleasure to introduce Dr. Grace, or Miss Grace Khong, who's a pediatric ENT consultant here at Alder Hey. She's only started recently in September last year. She was previously a senior clinical fellow from 2018 to 19 and then became a local consultant since 2021. She's trained in India and in the Northwest, and she's done a fellowship here in Liverpool. So we're really pleased that she's going to be talking about ENT and its impact and management in congenital. Thank you, Grace, and welcome.
Thank you. As he introduced, my name is Grace Khong. Hold on, let me just see if this slideshow works. Doesn't seem to be moving. Get it. Can you see the slide? I'm assuming that you can see the slideshow.
We can see the. You haven't started the slideshow yet. Okay, now it's on.
Yeah, it's moving. Okay, great. My name is Grace Khong. I'm one of the consultant pediatric ENT surgeons here in Alder Hey Hospital in Liverpool. I have a special interest in rhinology, and when Salim asked me to give a presentation in your talk here, I was thinking what important information would you want from ENT? And what I've come up with is 3 different scenarios that I feel is the most common scenarios where ENT and cardiology or cardiothoracic come in contact. And we can discuss about, from an ENT point of view, what our thought processes are, what concerns us, and then we can discuss what you would like, the information you would like to get from us in these patients. I'm sure a lot of you will be very familiar with all the scenarios that I'm going to discuss, so it'll be a nice discussion at the end. The first one is a patient who presented to ENT, actually, referred to the ENT clinic, a 10-month-old with noisy breathing, which is worse when he was feeding and when he's sleeping. He had symptoms very classical of laryngomalacia, which is stridor, inspirative stridor, but he also had symptoms of gurgling and choking and coughing, especially when he's feeding, and he's just not able to feed for a very long time. There was no increased work of breathing, so no tracheal tug, no subcostal recession when all of these episodes happened. So what we were thinking, what we start thinking with this history is laryngomalacia, possibly aspiration, also maybe a bit of reflux. On clinical examination, he had actually a little bit of tracheal tug. and it had this soft inspiratory stridor. And from ENT point of view, when it is inspiratory stridor, all we're thinking is obstruction at the level above the vocal cords. When there is an obstruction at the level of the vocal cords or at the subglottis, it's a biphasic stridor that we get. And if it is anything lower down, it's an expiratory stridor. So this boy, what we were thinking is possibly laryngomalacia, so at the level of the larynx. FNE stands for flexible nace endoscopy. So on flexible nace endoscopy, which is something that we can do in clinic or even by the bedside, that is, we use a flexible scope through the nose, and it goes through the back of the nose to the back of the tongue, and we are able to see the vocal cords up to the vocal cords. We can't see the subglottis and we can't see the trachea with a flexible nace endoscopy, and this is done with the patient awake, of course. So FNE showed possible laryngomalacia, which is tight aryepiglottic folds. So laryngomalacia can manifest itself clinically with obviously a stridor, but when you do the FNE, what you can see is basically a tight supraglottis. And sometimes, if in very severe cases of laryngomalacia, you can actually see the collapse of it. So the epiglottis can move posteriorly and it can collapse the airway. Both vocal cords were mobile. So this child, because this child was putting on weight and all, he was treated for reflux, because reflux and laryngomalacia can be synergistic in their presentation. So he was treated with reflux, but he came back to clinic again because it wasn't getting any better. So what I advised was microlapryngoscopic bronchoscopy under general anesthesia, which just essentially mean an examination of the airway. So from the nose right down to the carina. And we do this under general anesthesia with the patient spontaneously breathing, because you can see in these images, there's no endotracheal tube in place. So the first image on the top left is what we first see. So you can see the inlet of the larynx, so the epiglottis with the two vocal cords and the arytenoids. The area between the arytenoids and epiglottis is the area epiglottic folds that was quite tight, but the vocal cords look fine. Then further down, we looked at the subglottis area, which is also okay. So subglottic stenosis can also cause all of these problems. Then lower down, you see, so if you look at the top right photo image, you can see what the dimensions or how the shape of the trachea should be looking at like. So a C shape with the trachealis muscle posteriorly. But then as we go posteriorly, so the bottom left, you can see the tracheomalacia that's going on here. So tracheomalacia just shows that it's collapsing. The trachea is collapsing, but the etiology of it could be either a problem with the trachea. For example, if you have a tracheoesophageal fistula, you usually have the surrounding trachea where the fistula is usually a bit softer. So every time they breathe in and out, it collapses. When they breathe out, it collapses. And sometimes you can have external compression also, which is what we observe in this child. So you see the lower 1/3 of the trachea, you can see the rings here, but there is a very obvious collapse, I would say anteroposteriorly, but more on the right side. And you can't see it obviously on the images, but it was pulsatile. But when we went distal to this is the carina, and the carina looked fine. So in instances like this, because we have had so many patients like this before, we send the patient for an elective CT angiogram to look for any vascular rings. But usually in a patient like this, where it's very obvious that there is vascular compression, I do speak to my cardiology colleagues even before the scan is done, just so to prompt them to let them know that I have a child like this and I'm sending for a CT angio. And once the CT angio is already done, then we attend the cardiology MDT. Firstly, in one way is to show them the images and the video to see the severity of it. Secondly, it's also to discuss the patient's symptoms. What I would like to stress is, and this is not just for vascular compression, is for any tracheomalacia. It doesn't mean that an intervention is needed for every patient who has tracheomalacia. If they are managing well, and when I say managing well, there are two issues that I'm concerned about. One is their breathing, and another is feeding, because they have to be putting on weight well. We depend on them to be putting on weight well to grow, for it to get better, because tracheomalacia can improve. It is possible to improve with growth as they grow older. So this is what we tell the parents also. Even with a picture like this, it's entirely up to their symptoms and how well they're thriving. So this patient went on to the cardiology MDT because he did have a vascular ring. And we discussed about his symptoms because he did not improve with this. It was affecting his feeding also. And just for your interest, so this laryngomalacia with the tight AE4, what we do is we snip this area here that is tight, open up the airway. The reason we did this is he firstly had inspiratory stridor. Sometimes because it's like a tube, the airway is like a tube. So if there is an obstruction on the top and an obstruction on the bottom, the obstruction on the top in the more proximal part can cause the distal obstruction to be worse because of the loss of physics. So sometimes in these patients, we have seen where if you fix the laryngomalacia, they just get enough of air to go through to stent the trachea open, and they may not need any intervention for the vascular compression. The management of vascular compression, I will leave to the cardiothoracic surgeons and my cardiology colleagues to elaborate on that. But what I'm trying to show is not all complex cardiac patients will come through cardiology referred to ENT, but this is an example of a patient presenting with an ENT problem and found to have cardiac problem. And you can see that he was 10 months old, so he went on for 10 months and he was managing fine. The next patient is the other way around with the referral. So this is something that we do get quite, I would say, not very often, but it can, we do get quite a lot of referrals like this. So this is a very classical referral post-op in an ICU following a cardiac surgery with failure of extubation. And I put it in a very general way because when we as ENT surgeons hear about what cardiac surgeries you do, honestly, it goes all over above our heads. All we want to know is, was it near the greater vessels and was it near the vagus, the recurrent laryngeal nerve? So mainly these patients will be referred with failure of extubation, or they will also say after extubation they have a very weak cry. And then we ask what surgery was done and whether the patient had ECMO after surgery and which side was the ECMO. And I'll explain to you why. So this is an FNE. So the one on the left side of the screen here is an FNE of one of our patients who had a similar presentation. And you can see here lots of secretions. But if you look closely, it's only that's the right vocal cord that is moving. So he had a left vocal cord palsy after a cardiac surgery. And this other patient here on the right side is a very, very rare bilateral vocal cord palsy. And I'll just show you the video just to see the comparison in the airway and the movement of the vocal cords. So you can see here the laryngeal inlet here is really small. And you can compare with the pictures, the images of the MLTB from the previous patient to know how much the airway is. I would say it's even less than 10% there. So what do we do for these patients? So, and why does it happen? So on the left side, it's mainly on the left side because the left recurrent laryngeal nerve hooks under the aorta and travels up to supply the vocal cords. And on the right side, we call it's not, the recurrent laryngeal nerve has a shorter pathway. Any surgery on the left side can injure the recurrent laryngeal nerve. Like I said, very rarely you get bilateral. Interestingly, that patient who had bilateral vocal cord palsy was because he had a cardiac surgery and he also had a needed ECMO after that. And the ECMO was done on the right side. And with the ECMO, the recurrent laryngeal nerve was injured. The injury to the recurrent laryngeal nerve is like injury to any other nerves. So if it is only neuropraxia or exonotomosis, then it's not. They can recover, but it takes a really long time for them to recover. So we say at least 6 months to a year for it to even show some recovery. If it is totally transected, which to be fair is very rarely that happens, but if that happens, then very unlikely for them to recover. So what did we do for all these patients? And similarly to the patient that I discussed earlier, our main issue will be to airway and feeding. So in unilateral, and it's not a very, it doesn't hold true. A lot of people feel that, automatically, if you have bilateral vocal cord palsy, you're definitely going to lose your airway and you'll need a tracheostomy. And if you have unilateral vocal cord palsy, your airway is fine because the other side will compensate. But that's not necessarily true in 100% of patients. There are patients with unilateral vocal cord palsies who don't do well and do need airway adjunct surgeries. And there are also patients with bilateral vocal cord palsy who very interestingly don't need a tracheostomy. So in unilateral vocal cord palsy, what happens is, so you could see in the video there, one vocal cord is in a paramedian position and the other vocal cord is moving. The other vocal cord can compensate with the airway. Most of the time it can. But what happens is the patient can have aspiration. Aspiration happens when there is no protection of the airway. Airway is protected through the larynx. So the this has to go posteriorly, the vocal cords have to come together and they have to adduct or they have to meet in the midline to stop the aspiration. But what happens in a vocal cord palsy is that the vocal cord that is paralyzed will be in a paramedian position and the other vocal cord will only come right up to the midline. But some patients, the opposite normal vocal cord will actually compensate and move just a little bit further to the opposite side to protect the airway. So some of them do manage airway-wise and for feeding also. With bilateral vocal cord palsy, it's very rarely that you get aspiration. As you can see, there's hardly any laryngeal inlet there. But like I mentioned earlier, if they're not managing with the airway, they do most of them end up needing a tracheostomy. But what is important also is to explain to you the process that we go through in determining whether a patient needs a tracheostomy or not. It is a multidisciplinary approach. We don't decide on a tracheostomy on our own. It is together with, obviously, the cardiologist and the cardiac team will be the primary team, but it's also ICU because they are the ones who manage the airway when they are trying to extubate a patient. And it's also with the long-term ventilation team. Many years ago, tracheostomy used to be done very, very commonly in patients. But because of the advances by the long-term ventilation team with high pressure oxygen, CPAP and BiPAP, it has reduced the number of times that we actually needed to do a tracheostomy. So what we always like to say is a patient will earn a tracheostomy rather than a one-sided decision on whether they need a tracheostomy or not. With regards to the swallowing, we work hand in hand with the speech and language therapists, so the SALT team, so they assess the patient with their feeding, including a video fluoroscopy to see if they're aspirating. And it's the same thing with aspiration also. So there are many other things that they can do before they will say that this child cannot feed orally, and then they end up with either a nasogastric tube or eventually a PEG. These patients are, so from the time that they're seen by us and diagnosed, we see them every 6 months to do a flexible naso endoscopy in clinic and to see, just to follow up with their progress. And I've seen quite a few patients post-cardiac surgeries with vocal cord palsy who manage well and also with the palsy returning back to normal. The last patient that I would like to discuss, which is quite ENT heavy, but I thought it would be nice for you to know what exactly we do and why your patients look a certain way when they come back from surgery with us. This is a typical referral for a charge syndrome. So we discussed two patients where one patient is coming from ENT to cardiology and another patient is from cardiology to ENT. And this patient is an example of a patient who will be referred to both of us at the same time. So this patient was intubated at birth due to breathing difficulties, and they give the classical history of inability to pass a nasogastric tube through the nose on both sides. And subsequent ENT assessment showed bilateral choanal atresia. The reason why these patients end up intubated with bilateral choanal atresia is because neonates are obligate nasal breathers, so they're not able to, they will automatically be breathing through their noses. So as soon as you block the nose, they start to have breathing difficulties. And most of these patients will end up being intubated at birth and then transferred over to our hospital for further management. Some of these patients, from my experiences, they would have already been diagnosed antenatally with some cardiac issues. So cardiologists may already be aware of these patients, or some of them don't. They just present with choanal atresia, and then we start off all of the multidisciplinary work on this. So this is CHARGE syndrome. So it stands for coloboma, which is for the eyes. So we need, so we get ophthalmologists to see the child. Heart anomalies, atresia of the choana, restricted growth, genitourinary anomalies. So they do get an ultrasound KUB, and ear anomalies. So for ENT, there are two things that we are looking at for these children, but the main issue will be the airway with the choanal atresia. The investigations from our side, we confirm it, so we can do a flexible naso endoscopy on bedside, even if the patient is intubated, we can do that. But we also confirm with a CT head. In the CT head, we are looking to confirm the atresia, whether it's unilateral or bilateral, but also to look for any other bony abnormalities of the airway. So you can get mid-nasal stenosis or periform aperture stenosis. There is a higher possibility of a child having a second pathology in the airway when they already have one pathology. So our management is always to also look at rest of the airway, which is microlaryngeal tracheobronchoscopy, which is what I mentioned before. So the definitive management for us is to repair the choanal atresia and also to check the rest of the airway. But our concerns when we are working up a patient like this is, of course, if the patient has not been seen by cardiology, we get a cardiology review. And because they are an airway patient, they might have some cardiac problems. It is very crucial for us to be planning the surgery properly. And because the patient is intubated, we don't rush to do the surgery. We always make sure that we have cardiology input. So I think our cardiologists, they do an echo, they do an ECG. Usually we get a cardiac anesthetist to anesthetize the child for the surgery, and then we get all of the other MDT teams to see the child before we plan for the surgery. And it's also very important to note that all of these children are really small. Surgery becomes a little bit longer. So for these children, I have another slide that shows about our concerns during the surgery and how it pertains to cardiology. So a little bit about how we do it. Just I'm sure it will just shed some light on what exactly we're doing during the surgery. So this is the setup for choanal atresia repair. This is the classical way that we do. We go through the palate. So you can see here, so this is a mouth gag that is placed. The child is placed with a neck extension. This long stainless steel thing here is the endoscope. The endoscope here is not at 0 degrees, it's 120 degrees. So it gives us an indirect view behind the palate. And it's above the palate where the choana is. So you can see the surgeon has, the assistant here is holding the camera. The camera shows at the back of the nose, and the operating surgeon uses dilators. These are urethral dilators that we use to open the choana. And this is how it looks like. So with a 120-degree scope here, you can see, so this is the palate at the bottom because we're upside down. That's the palate, and this is the opening of the corona. And this is the posterior part of the septum. And here's a eustachian tube opening in the side here. So we are putting the dilators through, following the dilators through the floor of the nose, and then it coming out through the corona here. So it's almost just by feel that we are doing. And we do serial dilatation with the urethral dilators and increase in the size as we go along. And you can see here in the second image, this is where it's already been done on one side, and this is the dilator through the opposite side. And this is how it looks like at the end. So you can see how big it is at the end of it. Although I would like to point out also is what you're looking at over here looks really big, but it's actually really small, especially when you have these children, these babies who are less than 3 kgs and all. It's really small dimensions. This itself would be about 4 millimeters the most. So we have to dilate. So even if we dilate it, there is a high possibility that it can scar over, not because you didn't do the surgery enough, but because the dimensions are so small already. What we also do is we remove the back part of the septum, the posterior part of the septum, to give a bigger area for us, because you can see over here, the septum here is quite thickened. And that's a classical appearance of a child with choanal atresia. The posterior part of the septum tends to be thicker. The lateral wall also tends to be very medialized. The lateral wall is the pterygoid plates, and those tend to be very medialized. So the whole area is already more narrow than it is in a child without choanal atresia. But this is what we're working at. This is a very conventional method of doing of opening a choanal atresia because of the development of our equipment, and we have smaller equipments also now, smaller cameras. What we can do is we're moving more towards an endoscopic repair of the choanal atresia. So instead of going through the mouth to the back of the palate, we go through the nose with a smaller camera and go directly onto the atresia. When we do that, what we're able to do is to create mucosal flaps. So you can see over here on the right side here, this is a mucosal flap here. Remember previously I said that once you dilate, what you're creating is a scar area, a raw area all around, and that's a very small dimension also. So it has a higher propensity to fibrose and to scar over, and then you have a failure of the surgery. But with this, because you're using a mucosal flap, it just covers that area, so there's a less chance of it actually scarring over. So these are a few studies that have come up with the technique. There are many people who are trying this, including us. But it's something for us to aim at, but also to audit our results to see whether it actually is successful or not. But from your point of view, the more important bit is how long it takes to do the surgery. Is it bloody or not? And whether the patient will be able to withstand that longer general anesthesia. I would say that both dilatation, which is a conventional method of doing, and the endoscopic method, both take around the same time. I think from the time we start to the end, it takes less than an hour for it. And even what we would feel is that because the nose is a highly vascular area, and we usually think that it's going to bleed a lot, but it actually doesn't. And one of the ways that we make sure that it doesn't bleed so much is we use topical adrenaline. So we use 1 in 10,000 adrenaline on neuropathies, and we place it in the nose one is to decongest the nose, also causes vasoconstriction. However, we are very careful with this because, from anesthesia point of view, it can cause tachycardia. So we use it very sparingly, only when we actually need it. But to be honest, these babies don't bleed as much as you think they do. And it's also about the instruments that we use. Like I said, it's all really small instruments. So sometimes we even use instruments that we use in the ears for these children. And this is just a slide to show on how small it is to see. So you see over here that the length, the superior inferior portion of it is about 5 millimeters, which is just slightly bigger than our usual nasal instruments. One more point that I forgot to mention is about the CT scan and what we're looking at the CT scan. If you remember with the mnemonic of charge, there is also ear anomalies that can occur in patients. And what we're looking for in the CT scan is also inner ear anomalies. But that's the main thing. Some of you who might be quite senior and who have been around for the last 10, 15 years would remember seeing babies coming out of choanal atresia surgeries looking like this. So remember when I said about how we can scar over very easily. It used to be practiced to put a stent through the operated site. So we put like a nasopharyngeal airway that goes right to the back and it stents the area open so that it doesn't scar over. The stents used to be placed for a few weeks and the carers were taught how to use the suctioning to keep it open. But what has happened, what a study in 2015 has found out is that whether you use the stent or not, it doesn't make any significant difference to the percentage of the success rates or the number of revision surgeries that these children end up having. The average number of surgeries that these children require is about 3. So even if you use the stent or you don't use the stent, it is an average of 3. And personally, I don't think it is anything to do with how well the surgery has been done. I've seen some children, some babies who we've done really good repairs and it looks really, really big, but it scars over really fast. So it's not about how the surgery is, but more about the child and also about the size of the child. So we are moving away from placing stents because what they've shown is that if you can look at the picture there, the stent actually sits on the alar of the nose and that can cause pressure necrosis also of the alar and can change the shape of the nose. And it's also very uncomfortable for the baby to have it. So in Alderhay, we don't use stents anymore. For the past about 5 years, we haven't been using any stents. But what we need after surgery is some nasal drops, some topical medication to help increase the chance of a success in the surgery. And the nasal drops that we use is either steroid drops, ephedrine, or even Otrivin. The problem with these is that none of it is actually licensed for babies. Otrivin, which we all know very well, even non-clinical people know about Otrivin. Otrivin for pediatrics is only 6 years and above. So it's not licensed for babies. Steroid drops is not good because they can have systemic absorption of these steroid drops, and methamphetamine has very high systemic absorption, and we know about ephedrine. So we use this very sparingly, only for about 3 days, maximum 5 days. Some of us have tried with suctioning, regular suctioning also, but what they say is that it's just like with a tracheostomy tube. If you keep on suctioning it, you're going to make it scar more and you're going to cause more raw tissue. But this is what we consider after the surgery. The follow-up for these patients is usually directly from to theatre, meaning that we don't usually see them in clinic. We schedule a follow-up surgery or relook a few weeks after. So it depends on how confident you are with the surgery. So in smaller children, we do it about 3 weeks after the first surgery. So we just schedule them for another surgery and we take a look and we repair it again or we widen it. So we don't waste our time seeing them in clinic first because we know that most of them are going to start scarring over anyhow. So they go directly for another surgery in 3 weeks. And then after that, subsequently, it depends on how it looks like after surgery. And then we decide whether they need another surgery, we can see them in clinic. But that's it. And that's the end of my presentation. And I'm happy to take any questions.
Thank you, Grace. That's a fantastic talk. It's really nice to see what you guys do on the other side, and also how you guys get involved in some of our cases. I'm just gonna, one of our audience members got a question.
I was just wondering, after cardiac surgery, we obviously quite often see stridor post-procedure. How quickly do you guys want to be involved when they come back and they've been extubated and we notice, is it something that needs to happen within the first week, or do you want to be, do you think it's better to leave it for a few weeks?
I think it depends on how the child is doing with the stridor, because with intubation also they can have some swelling around the airway, and that usually reduces after 24, 48 hours. So it depends on whether they are struggling or not, because, and also during the surgery, you feel that you may have injured the nerve, whether there's a possibility of a vocal cord palsy, because what we're doing essentially is just to tell you whether there is a vocal cord palsy or not. And we are happy to see the child whenever, because it just means that we're just going to put a scope in and let you know whether there's a vocal cord palsy. So it's entirely up to you and up to how the child is managing with it. From what our experience is, usually I think in ICU when they are extubated, first there's a trial of some steroids, because you assume that it's maybe just airway congestion and airway edema, and then if that doesn't work, then you ask us to see. But there are some children where they are clearly stridulous and clearly have a airway obstruction, and you need some answers. Then we come in to do a scope.
I think the fire alarm has just gone off. And this is not a test. I'm really sorry. Everyone's evacuating their rooms. So we'll have to finish up here. Thank you very much.
You're welcome.
Running out. Thank you. Bye.